thing on the left. So yeah, I think you're right. I'll make it back. I'll leave it. The STD clinics are always, yeah. Well, that was
Okay, let's get started. We are on the home stretch. For those of you who are hanging out with us right now, thank you so much. Let's talk about some cases. All right, first case, we have a 29-year-old female. She's G8P1. She comes in at 21 weeks gestation for assessment. She has no fetal movement detected. She's had multiple miscarriages in the past, numerous gonorrhea and chlamydia infections. She got prenatal care in her first trimester. They did just an HIV test that was negative. 8 weeks later, she had an RPR done that was non-reactive. So sort of a disjointed collection of her prenatal labs. So the team called you to assess her. What are your thoughts? We'll start with you, Jody.
Pick up the little thing,
is this
yeah. Just talk into that, the soft end. You can hold it.
Just hold it? Stuff like this?
Yeah, that'd be great.
I'm sort of squinting to try to see this. So this looks like this is a woman who's had a lot of pregnancies in the past, but a lot of miscarriages. So I'm already worried that there may be something either genetic or with her cervix that makes it difficult for her to bring pregnancies to term. The no fetal movement makes me worried that this is a stillbirth presentation, and even though she was HIV testing negative at some point in the first trimester and RPR testing 8 weeks later, both of those need to be repeated now. Every stillbirth needs to have an RPR tested in pregnancy. So I would want to look carefully at all the STI testing she's had to date and her track record in her prior pregnancies. Did she have congenital syphilis before, and was there another explanation for all of her pregnancy losses?
Anything else from the panel?
Next.
All right, so she is, we take a good history, we already did that, and you examine her, and this is what we see. Dr. Edwards, what are some of the things that are in your differential when you see a woman come in with that type of lesion?
Am I to assume that your pictures aren't as pretty as mine?
No, your pictures are
Am
lovely.
I to assume that that's an ulcer right there? Yeah. Okay, because it looks like an ulcer rather than an erosion. A chancre, probably not an aphthous ulcer. At the time of delivery, that would just be too mean. Herpes, if she turns out that she is immunosuppressed for some reason, but she shouldn't be immunosuppressed already if she has just developed HIV. And I would also check her for any bacterial infection that has eroded through, like a furuncle or something. It is not the best I can tell from the morphology, which is not easy, it is not good for any of the other morphologies of that I was talking about, and I would also consider CMV if she is immunosuppressed.
Great, thank you.
Can we check our audience?
Yeah, so let's poll our audience about what the next steps are. Okay. So RPR, HIV test, comprehensive STD screening, arrange for outpatient OBGYN follow-up. RPR, HIV test, treat with some valacyclovir. Talk to a partner, and RPR HIV test, treat with BPG, some partner therapy there, and RPR HIV test, local wound care.
Let that spin for a few.
Okay.
We need some interlude music.
Dr. Swigart, what do you think?
I mean, I think in this situation, there's no fetal movement. I do think that obviously we're going to have her checked out by OB, but I'm assuming this is
Assuming that she's already lost the pregnancy, I mean, you might have a little bit of time to follow up on your labs and be sure, but I think I would lean more towards the RPR HIV test, treat, and manage the partner. The other question I had was for Dr. Edwards, any sort of connective tissue disease, like I don't know, anticardiolipin antibody sort of
Causing the ulcer?
Well, or causing the fetal loss, like could she have some sort of connective tissue disease or collagen vascular rheumatologic thing that would maybe cause a genital ulcer like that too?
Not that would tie this together, causing a genital ulcer. Certainly there's some autoimmune diseases like antiphospholipid antibody that can be associated with fetal loss, but not that would be associated with an ulcer unless she is being treated for them and is on prednisone.
Dr. Mobley?
Didn't you show the ulcer was at the time of delivery? Was she delivering the still form?
Exactly.
Okay. No, I mean, the only thing I would add is that in the North Carolina law, following up on any stillborn from a female requires like examination for syphilis and rule out a syphilis. So making sure that happens is important.
Okay.
All right. So this brings us to a good point, and you probably have seen some of these slides already in Dr. Dionne's lecture. But I wanted to highlight that, especially in reproductive age women, we are concerned about syphilis, though the epidemic is most prominent in our men. In North Carolina, we're in a high morbidity zone, as well as in the western portion of the United States, and we're seeing primary and secondary syphilis rise concurrently with congenital syphilis cases. So another thing that we have to keep in mind is this intersection between the opioid epidemic and what we're seeing in our women. And indeed, in this data we have from Kidd et al., we're seeing that there's definitely a signal out there that we need to be looking closely at this. And this brings us to where we are. So our early syphilis cases, more likely than not to transmit to the baby during that time frame. And untreated infection can have significant complications with a wide spectrum of disease. And then in terms of screening recommendations, all screeners first visit, and in this individual it seems like there was some disjointed screening recommendations for her, but you would also want to make sure they got screened in the third trimester and then again at delivery. And it really depends on where you practice, in that here in North Carolina, we make sure that people get screened throughout many stages of pregnancy, but there are other states where, believe it or not, it's only required at the first visit. So, and if you look at the map, one of those states is actually an area that's in the really high morbidity zone for congenital syphilis cases. So keep in mind where we practice, and then you can probably see your county somewhere here. Again, rising cases of congenital syphilis, so we really need to think about this closely. And then time to treatment. So guess what? We do a super awesome job of getting individuals, men, treated in a timely fashion when they come in with their primary stage disease, but we don't do such a good job with women. So those are thoughts I want you to ponder on this case so far. So the case continues. Maternal RPR is performed. It's reactive at 1 to 128. She got treated, and our DIS team actually went ahead and interviewed the partner and found that the partner had primary syphilis, and that partner was treated as well. So can you identify any potential missed opportunities for prevention in this case? Dr. Dionne?
So it does sound like she got first trimester screening, although not at the same time as her initial visit. So that's one miss. She didn't reach 28 weeks, so she didn't even get to the second time point when you'd be expected to do syphilis screening. I think that while ideally women would know if they're at risk of their partner giving them syphilis in pregnancy, a lot of women are not aware that their partners have outside partners. So even asking that question in the visit may not be able to pick up that that woman is at risk. I think there's still something curious with all the other miscarriages she had in the past to understand what that is. There's a story there we don't understand yet. I doubt that was syphilis for every single one of those cases, but I would do digging until I understood better what the history was there. The timeline, I mean, here she was obviously, it sounds like she was admitted, had the stillbirth, and treated at the same time, so there's no time delays, at least from what I can tell. And the partner treatment was appropriate.
Dr. Mobley?
I agree, but I will say that in reviewing all the congenital syphilis cases in North Carolina, we do see a lot of missed opportunity because the man had been diagnosed previously and treated, and during his interview, he didn't name anybody, or he didn't name the pregnant female who may have been his primary partner, and he didn't want that person to come back to him and say, you're the one who gave me syphilis. So we really have to do a better job of getting our male patients, one, making sure that when we interview them, we ask specifically about female partners, particularly of reproductive age, and if any of them are pregnant, and highlighting the importance of making sure that they give us the name so that we can get them tested and treated if they do have pregnant partners, because we miss that a lot with partner notification.
Dr. Swigard, we have really robust programs for hepatitis B screening in women. Is there any way you think that that type of program could be used for congenital syphilis in the state of North Carolina?
Well,
Like the high-level screening, the recommendations that are out there in terms of how we manage patients when we're trying to prevent hepatitis B and going to the baby.
well, I believe in North Carolina we're required to do syphilis testing in the first and third trimester, and then again at birth if the mother hasn't been tested. So I mean, I feel like that's fairly robust in terms of pregnant women. Women coming into family planning clinics, certainly they're sexually active, and so pregnancy may or may not occur. That's certainly an opportunity to do syphilis screening there. I guess I'm not understanding exactly what you're asking me.
So in some states, they model congenital review boards after some viral illnesses where we have managed to do great jobs at preventing transmission. Unfortunately, we don't have a great model for preventing congenital syphilis so far, despite really great recommendations for screening. So I was wondering if there are any other disease processes that we're currently, screening out against that we could potentially model a congenital syphilis prevention program. And I thought about hepatitis B as one.
Well, I think certainly any woman who we don't know to be hepatitis B surface antigen positive is screened for hepatitis B with her pregnancy, and then again, if we're testing for syphilis in the first and third trimester, because that first trimester, I think in this case here, maybe not in this case, but if a woman is, I think Vicki had shown this as well, that there are a fair number of women who are being diagnosed with syphilis actually later in the pregnancy, and they were negative at that first visit. So I think it's currently fairly robust in terms of how well we're screening. Yet we do still have a fairly high number of patients who are with congenital syphilis.
Yeah, so I agree. I don't know if we have an answer. Were you going to say something else, Dr. Movas? No? Just moving the mic? Okay. So all of those things you mentioned and more, in that, the way that at least a model that you can look at is looking at it through the continuum, starting from preconception, making sure people get appropriate screening starting from that point, and then also moving to prenatal and then birth, making sure along the whole spectrum that we have public health engagement along the way to try to prevent congenital syphilis. Unfortunately, we don't have a really great solution to it at this point in time, but over time, I am optimistic we will impact this. So this particular case, the case of syphilitic stillbirth, in a fetal death that occurs greater than 20 weeks, where the fetus weighs greater than 500 grams and the mom was untreated or inadequately treated. So bringing back the point here, we need to make sure that women are screened appropriately throughout pregnancy, that an individual has an RPR performed if they have a stillbirth greater than 20 weeks. They get the penicillin based on the disease stage they have identified. They have comprehensive HIV care, and that partner management occurs so that we can interrupt this transmission cycle. All right, another case here. We have a 32-year-old female who's coming in with persistent vaginal itching and irritation. She presents for an urgent care visit, primary care office, and in reviewing her history, you find out she has an allergy to metronidazole, noted during a hospital stay, ? It was actually unclear whether it was allergy or not. She had tongue swelling, which was either due to tongue trauma or the metronidazole, and they weren't sure. She was labeled as allergy. She had a recent treatment of intravaginal iodine, which is quite curious. And when you talk to her about her partners, you do the 5 Ps. Partners, yeah, she has multiple sex partners, and she is a sex worker. She has one consistent male partner, one consistent male, and then many others. She is exposed at all sites, reports polysubstance abuse. She's had STDs. You asked her that question, and she said yes. Uses intermittent condoms and has no pregnancy plans, but is not on any contraception. A few additional questions. You asked her some extra Ps. There's no partner violence or interpersonal violence that she's concerned about. So what do you think? This is what you see. Now, I was very tempted to cut off the speculum in this picture, knowing that people will focus on the contents of the speculum there. But take a look at the actual labial part of this and let me know what you think. Dr. Edwards.
Well, she looks like she has got erythema that's abnormal, probably, and she has a purulent vaginal discharge with some patchy redness in her vagina. So it appears that she's going to have an inflammatory vaginitis of some type.
Any other comments from the panel? So what would be your next step if an individual came into your office with these types of complaints?
I would do molecular testing for gonorrhea, trichomonas, chlamydia, do a wet mount, and probably that would be pretty much the way I would start with this, and then wait and see what I got.
Do you think that the intravaginal iodine could be something that contributes to this appearance?
I suppose it could. It could certainly cause the redness. I'm not so sure about that remarkably inflammatory green vaginitis, but it could surely cause the skin findings and maybe the discharge.
Dr. Swigert, any comments?
Looks like Trick from the vaginal discharge.
You can't tell. You can't tell. Good try. You work in an STD place.
Yes, this is exactly the debate I wanted to cause. I'm glad the two of you sat next to each other. So I put this chart here because I wanted you, having absorbed all of Dr. Edwards' slides, to think about the possibility that this could be something else before you put the speculum in, other things that could be in your differential. This wonderful table is actually adapted from your book, Dr. Edwards, and looking at all the different causes of contact dermatitis, irritant contact dermatitis versus allergic contact dermatitis. And in her, there could potentially be something in there in that if she has an excess of vaginal fluids, that's definitely something that can cause irritation. And then also, I don't know about this iodine in the vagina, but that could potentially be a contributing factor. Vaginas aren't meant to have iodine in it. But that was just one of my thoughts. Dr. Mobley, any comments?
I learned a lot from the earlier talk.
Well, I do have a comment about the iodine. Kind of wondering about that, but we use iodine all the time for colposcopy. Yeah, these are all the time.
Yeah. Mm-hmm.
So are you like, you know something I don't know about iodine?
This was an iodine, like it was a vaginal lavage with iodine. And some people can have allergies or hypersensitivity reactions to common things that we use topically. So it was just.
In general, you don't get allergic contact dermatitis on a mucous membrane like in the vagina. Now, the outside, where it comes back out in the vestibule and on the vulva, you can, but you wouldn't expect that inside the vagina, an allergic contact. Irritant contact, sure.
There's a question in the back.
Yes, that's it.
Steamed it? How do you steam your vagina? No, I'm serious. I mean,
So the question that's being proposed by Nicole is actually a scenario. She saw a patient very similarly who had steamed their vagina using a lavender oil base, and she's going to let us know a little bit about steaming of the vagina.
Seems like that would cause burns.
Thank you. All right, so, yes.
Just to clarify, it's not like with an iron steaming. It's basically just hot water with aromatherapy, and you kind of like spit or squat over.
Yes, I believe that's aromatherapy for
so
the
you don't
vagina,
insert it.
No, it's not like.
Aromatherapy for the vagina is also not recommended, but thank you. All right. So this is so in following that thought, you get to decide to do a wet prep, and this is what you see. Any thoughts? Yeah. Okay. Great. So you did figure out what's going on with her. She had trichomonas. So So what is the most common reason for reoccurrence of Trichomonas vaginalis infection? I say reoccurrence because I should explain that the reason why she had the lavage of the vagina with iodine is because she had this documented metronidazole allergy. The primary care doctor had attempted to have her admitted for desensitization. However, that was not feasible, so the emergency department staff did a vaginal lavage with iodine. And it didn't appear to be effective in that she came in with this particular complaint. So yes, I would say reinfection is the most common cause, though I see some people think bad luck, and maybe that could be the case. Okay, so in terms of incidence and prevalence, again, we're in a high morbidity zone for trich as well. It's the most common treatable STD. Millions of people get it, unfortunately. About 13% of the general female population. The prevalence tends to increase with age, so this is one where we call this a disease of the older women, and older in reproductive terms is, questionable, but greater than 25, definitely greater than 40. Highest rates in non-Hispanic Black women, up to 47% of female prison inmates and 9% of men, 38% of women reporting a risk of drug use, which is the case for this patient, and then also commonly with vaginal complaints in the clinic. So another question here, and we'll just work through this as an audience in the room. So what treatment would you recommend? We have several different options here. So are we going to do metronidazole, 500 by mouth twice a day for 7 days? Are we going to do tinidazole, 2 grams for 7 days? Intravaginal boric acid? Are you going to put something else in the vagina? Are you going to refer for desensitization? Or are you just going to leave it alone? It's going to go away all by itself. Send her out. What's your plan?
What was the documentation of her allergy?
Right. So in this case, her admission to the hospital was she had an overdose and trauma to the tongue. And during that incident, so she had the tongue swelling there. They incidentally noted a vaginal infection, gave her the metronidazole. The two of them sort of coincide. So they said they didn't know if it was tongue trauma or whether it was the actual metronidazole. So she got labeled as metronidazole allergy. And that's as much as they can tell because she's not really able to give a good history.
And that's what slide are you on? 'Cause it goes down.
So what do you think? How would you treat her? We'll just work through this in the panel then, I guess. Yeah.
So with that history for me, I think I would feel comfortable re-challenging her with metronidazole. I'd probably do it in the clinic so it could be observed. Just to add for intravaginal boric acid, that's something that's been done by Jane Schwebke and Christina Musney at UAB with great success. So it sounds crazy, but that's in the literature. Case reports for the women who have true recurrences over and over again, they're not responsive to first and second line therapies or who are truly allergic.
Great. Thank you. Any other comments from the panel? No?
Except that I wouldn't give it to her in my clinic. I have a dermatology clinic.
Okay.
I'm not really equipped to
Yeah. And this particular doctor tried to troubleshoot this, and nobody on his staff would actually attempt the desensitization in the clinic, which is how she ended up in the emergency department with the intravaginal iodine lavage. But definitely, I would agree. I would feel comfortable potentially challenging this individual in a controlled setting versus, consider other possibilities as well. So there's actually probably more than one answer to this, and it depends on level of comfort.
The allergist is always a good person too. They're very helpful when you're dealing with allergy. If you're not sure what to do, they're helpful.
And then the challenge with allergy is with limited resources, and I think that was the reason why she didn't go to an outpatient private allergist office and ended up at the emergency department. Sure.
So if someone has a metronidazole allergy, I've never really tried the Tinac as an alternative to the same class. So is that?
That is exactly the case. You would not want to use tinidazole in the case of metronidazole allergy.
So the answer to that question is?
So in that case, so it depends on level of comfort, whether you think it's a true allergy or not. So if you think it is a true allergy, probably referral to an allergist for desensitization versus doing boric acid intravaginally would probably be approaches, and we'll review some slides really quickly on that. Versus if you're like, this is not a metronidazole allergy, you're able to get better history, better understand it, you can consider challenging in a controlled setting. So we have a few options, and part of it depends on the level of comfort. Yeah. All right. So in terms of testing, there are many different modalities. We can use the eye, as we did with wet mount, but you know what? We're not as good as many of these other technologies there. So the ones that are out there that we like to use are a nucleic amplification test, which can have a great sensitivity up to 98%. And then you can see way better than us looking at it by eye, with some range from 35 to 82%. And then it also depends on how quickly you can get it to the lab. So a number of factors why saline wet mount might not be the best, but it's a great point of care test that a lot of people have. It's really cheap. If you have a microscope, most people can get it done. And so in terms of other things we need to consider, one possibility, the provider, in discussing this case with me, asked if there was a possibility that she was resistant. Keep in mind, she may have had standard therapy partially with the metronidazole exposure, but after that she got intravaginal iodine, which can be used in some instances. It's an alternative, but it's definitely not a tried and true way to treat trich. So about allergy, just know that it's rare. With metronidazole, it's super rare. We're talking on the matter of somewhere between 4 and 10%, and tinidazole about 1%. When we've looked at data of, so is it resistant or is it treatment duration? Did she just not get enough metronidazole with the initial case, and that's why she's coming back with this recurrent event? Well, when they've looked at studies on treatment, if she were HIV infected, we know the tried and true way to do that is actually to do 7-day course versus a single course, and this randomized controlled trial showed just that. So if you look at the CDC guidelines, you're going to see these recommendations for initial episode would be that single dosing. And then also if you have an HIV-infected patient, the BID dosing for 7 days is your alternative, as well as if they were infected or if you're going on a different part of the algorithm. And then keep in mind in failure, there's also the recommendation to do the 2 grams dosing of, instead of the 2 gram dosing, going ahead to that 7-day therapy for either metronidazole or tinidazole.
There's also a new RCT. You getting there?
I'll let you do it. Yeah. We'll see the slide. Yeah. So, Jody, can you tell us a little bit more about some of the new data that's out there on treatment?
I just wanted to mention that there's a new RCT looking at the 7-day treatment for trich in HIV uninfected women, showing superiority to the single 2 gram dose. So we'll see if the treatment guidelines change, but this was a well-done study at a lot of different sites. And although we like single-dose therapy because we know patients are going to comply with it, the response rate was definitely better with the 7-day therapy in women without HIV, which is somewhat of a surprise.
Exactly. So, the treatment guidelines came out in 2015, and we have this great new data, so who knows, we might be treating trich differently in the future with more metronidazole. So that's really important in terms of new developments. And then I also want to highlight this thing with alternative therapies, because some people look at the guidelines and they see all these other things that are listed, and you can see them in different articles. So I want to say the tried and true way is going to be with that metronidazole. Other things that are there, you can do peronomycin. That can sometimes lead to labial ulceration, which would be a very unpleasant side effect if you're already having a labial problem. And then also combined with tinidazole therapy and then boric acid. This can be done, you can talk to your patients about contacting a compounding pharmacy and getting a formulation that they can use intravaginally. I understand there are ways that you can do it by looking this up on the internet. However, it depends on the level of sophistication of your patients. This might not necessarily be the way to go. All right. Don't forget about partner management. The patients and the partners tend to have the same process, and make sure they get rescreened appropriately. So the learning points is this is a highly transmissible disease. Be able to recognize the people who might be at risk for infections, try to manage them appropriately. In cases of allergy, really consider desensitization and to try to use the preferred therapy for treatment. Call a friend if you need help. There are many people out there. Our dermatologist colleagues are great in diagnosing skin-based problems. And then we also, if you're thinking about an STD and you need some help, contact us. Next case, we have a 24-year-old female who has a past medical history of chlamydia. They're coming in for STD screening. They have no medications. They are allergic to amoxicillin and cefuroxime. You ask them about their partners and exposures. You find out they had 1 male partner in the last 2 months, 2 in the last year. They've had vaginal sex only. They have no pregnancy plans. So you do screening, and your screening initially was negative. They come back in for screening, and this is what you find. Really complicated history, but let me summarize this. So they're coming in, they come back in for a screen visit with no symptoms. They're found to have gonorrhea. they're treated with gentamicin and azithromycin because somebody's really concerned about that amoxicillin and cefuroxime allergy. They come back in the following month, their screening is negative. The next month, they come back in for screening, it's positive again. And you notice they're still getting that gentamicin and azithromycin as the treatment. They come back in, it's negative, positive, negative, it's going on. And then 8-month visit, they're coming in, they're having abdominal pain, they're having bleeding, they're having vaginal pain and discharge, and some abnormal findings on examination. So what are your thoughts? Acute partner, that seems like a good option here, yeah. And I think I heard somebody say PID. Yeah. Panelists, would you agree? Yeah. Okay, so PID, this woman meets definitely the minimal criteria with her history that's there. And just remember that this is a polymicrobial infection most commonly that ascends. So what would you treat her with? Keep in mind that she has this allergy history. Okay, so I'll just ask the panel.
Going backwards. I don't know why it's not picking up where it was.
Okay, panel, what do you think in terms of her treatment? Are you going to pilot giving her ceftriaxone in that clinic setting?
I think you have to probably drill down on what the cefuroxime allergy was. If it sounded true, you wouldn't want to give her ceftriaxone. You'd be stuck. A lot of times, as I mentioned before, it's not true. So I wouldn't give her it without a clear understanding of what the allergy was, how long ago it was, exactly what happened, and read the chart for the documentation.
Okay, sounds fair. Anything else in the panel?
It also looks like she's failed. She's gotten gentamicin and azithro 4 times already, so relying on that as a treatment option right now doesn't seem like a good plan for her.
Okay, and then we also have a new diagnosis of PID as well to go along with it. So a little bit more on penicillin allergy, and you touched on this earlier on, Dr. Diane. Really what we're looking for is IgE-mediated events, and this is pretty uncommon. We know that also many of our patients who report penicillin allergy, this wanes over time, so that 80% of patients become basically tolerant of penicillin a decade later. And there's cross-reactivity that exists between your penicillins and your cephalosporins, but really it's lower than has been previously reported. So, Dr. Edwards, I was going to ask you, what types of genital manifestations could you potentially see in somebody who's coming in with a severe allergic reaction? So, in this charting, we're talking about skin, hives, rashes on the extremities, but what about the genitals?
The genitals usually aren't even looked at by the time you've got somebody who's got generalized allergic reaction, but certainly sloughing of the skin and including the vagina, the inside of the vagina can happen. And even though as dermatologists we're always careful to look after the eyes because of concerns about corneal erosions and blindness, it's really helpful to have somebody who is taking care of the genital area, because you can get remarkable scarring after just one episode of Stevens-Johnson or TEN with complete closure of the vagina.
Thank you. So along those lines, I will say do not challenge with penicillin or cephalosporin. In this particular patient, we might have more risk than not, especially if it's a true allergy. And in teasing this out, definitely if she had any mention of this being swelling of the mouth, face, collapse, intubation, those are all warning signs that it shouldn't be done. Yet still we're pressed to try to find the appropriate treatment, and the current recommendation is for the ceftriaxone and azithromycin. So that's really challenging in cases of allergy, and it can sometimes result in people getting less than standard of care while we try to troubleshoot and navigate that allergy, sometimes in the outpatient setting. So listed here, you can see in allergic patients, we're giving the gentamicin and azithromycin. With PID, so if you look at the guidelines, they talk about ceftriaxone, doxy, and metronidazole. And in allergy, you can see this little side part in the text where it says if the individual has low risk for gonorrhea, or if you're in a low community prevalence, then you can consider using a fluoroquinolone. We're in North Carolina. This is not going to work for us. So definitely a challenge for us, and this might be the time to involve your allergy colleagues so you can get appropriate treatment. Because here we're also seeing, just across the United States and even in Europe, rising in the MIC with the treatment for commonly used antibiotics and concerns about resistance. In Indiana, we've seen cases of increased MIC to azithromycin, as well as partner networks in Hawaii as well, so we have to pay attention. On the national level, there is a presidential emphasis in looking at resistant antibiotic threats, and you can see we have several sites across the country where we're surveilling this, one of which is right in our Guilford, North Carolina, in Greensboro, where we have a surge site and previously a GIST site. So GIST is a site where they monitor basically the first 25 males that are coming into clinic. They take a specimen, they check to see how resistant that gonorrhea is. And you can see in looking at this, okay, cephalosporins, we're still not doing too bad there, but fluoroquinolones is about 14%, and then you can see other combinations listed here. And this is looking at surge data. Surge data looks at men and women. And when we look at this, really we are mirroring the trends nationally in that we're seeing that cephalosporins are still doing pretty good with our population, and other things not so good in terms of fluoroquinolones. So in this case, don't forget to call for help. Consider doing a test of cure while you're trying to assess these patients. Just to summarize that this person got levofloxacin and metronidazole, ultimately had multiple visits in an attempt to resolve the infection before she actually had cure. So I'm going to go through this last case really quickly just to get your opinion on the last part of it. We have a 43-year-old man who's coming into care. He comes in with a plantar rash and a groin rash, which he says is itchy. He is HIV infected, has not been in care due to concerns about disclosure. Diagnosed in the 1990s, not on ART, borrowing ART from friends and family essentially. He has alcohol socially and some substance use history. He doesn't use condoms. This is the rash on his feet. So other things on examination, he has thrush, he has some findings, he has lymphadenopathy, he has maceration in many of his folds, he has scaling on his scrotum. And so what are you guys thinking? Throw out anything. Babies. Babies is a possibility, but it might not explain some of the other parts of his body, but yeah. Okay, scabies, and then what else? Syphilis, yeah, okay. Anything else? All right.
We always teach our ID fellows when you see the hands and the feet to think about Rocky Mountain spotted fever also. It's one of the other rashes that can involve the palms and the soles.
Yeah. Great.
Doesn't sound like he has that.
No, it doesn't. But you know what? It's always good to think about these other things too, right? So really important, as you mentioned before, a lot of our MSM patients are also co-infected with HIV. And we have the serologic test, but you know what? They're not totally perfect. When we look at the manifestations of secondary syphilis, for instance, in the beginning parts of disease, sometimes you're not having that reactive RPR, as was his case. So, some quick questions. Dr. Dan, what would you like to do here? Would you want to repeat his RPR in 2 to 4 weeks? You want to call the lab and say, you guys made a mistake, or ask for additional dilutions, some additional testing?
I missed it. Did you say he had an RPR that's negative?
Non-reactive.
Oh, then I would order the treponema test, like we were talking about before. It can be positive before the RPR is.
Okay. Dr. Mobley?
I want to treat him.
Treat him. Okay.
Yeah.
I would treat him too.
I mean, I would stick him, and then I would seriously start the conversation of why we are not on ART consistently.
Great.
Because could this be a HIV-associated rash from a pretty immunocompromised person? Absolutely. Okay. Sorry. I saw him giving me the evil look right when I finished talking.
Yeah.
Very sorry.
So his RPR, so ultimately he finally decided to engage in primary care, showed up at an eye doctor with complaints of decreased visual acuity, was found to have an RPR titer of 1 to 1,024 with a reactive TPPA. He did finally endorse that he was sexually active, and he had positive gonorrhea in his throat. So this was actually thought to be an example of a prozone phenomenon. And even though I will agree with you, Dr. Dayon, this is incredibly rare, we do sometimes see it out here, and particularly we can see it with cases of neurosyphilis and ocular syphilis, which is what this guy had, and he was HIV infected. As you mentioned, it's a dissemination of treponemes into the CNS system, and we've actually seen it being reported nationally. We saw it very prominently in 2014, 2015, and locally. I can see some of the authors for this sitting here with us. No? Yes? On that list there, and that we have actually had cases here locally in North Carolina concurrent with HIV infection, typically in individuals with really high viral loads as well. So, what additional portions of the workup should be done? He should also have a lumbar puncture performed, appropriate screening, neurologic examination, report that to the local health department so they can take care of it, and he's going to need IV penicillin for 10 to 14 days. So, my last question for you guys before we head out for the day. In this time of high morbidity for STDs in our area, do you think we're at a point where we need to be considering doxycycline for pre-exposure prophylaxis for syphilis?
You want to start with me? This is like the hot topic of every HIV STI conference we go to, whether or not doxycycline for high-risk people, which in the EPER-GAY study showed benefit. I think that in terms of increasing antimicrobial resistance, which we know is always going to happen for many organisms, if not TP, and the effect of antibiotics on the microbiome, I think it's too early to discuss giving people doxycycline in a large scale.
Right. Dr. Edwards, is doxycycline really relatively tolerated in your practice as a dermatologist?
It's well tolerated if you tell people how to take it and tell them not to take it on the empty stomach like the pharmacist often says. And the resistance thing is interesting since we have been using ongoing doxycycline for 8 zillion children with acne for decades and decades, and yet still it's one of our best medicines for some resistant bacteria. For my patients, for this particular thing, my patients don't have sex, so they don't have these diseases. My patients all have got so many vulvar and penile diseases that they've sworn off.
Thank you. Dr. Swigard?
I think that I would defer and not. I don't.
So
think
you
we're
think
ready
it's
for
not
that.
ready for prime time for a doxy?
I don't. I also think that it's hard to take. I think that it is, photosensitivity is an issue, and obviously we'll wait till literature comes out. But
I was going to bring up the same thing. I don't know if, I think the recommendation or what's being looked at is 100 milligrams once a day instead of the typical twice a day. But I don't know if that's associated with the same skin changes that you may see in more fair-skinned people who are taking chronic doxy. But I agree. I don't think we're there yet. And we can't figure out how to get people who initiate PrEP to continue on PrEP and take it every day. Yeah. I think we got to figure that problem out first. And then, talk about whether or not doxy would be useful in certain subpopulations for prevention.
So really briefly, the data on that, as you mentioned, we're still in a data gathering period, but they've done studies with PrEP, a population of 30 individuals where they did doxy versus conditional cash transfers. They took the medication 36 weeks, followed them really routinely. They found an overall decrease in STIs and also syphilis reduction. Looking at PEP, that's getting that doxy after you have sex. They found a decrease in overall STIs as well as syphilis. But I should say this overall STIs did not apply to 2 diseases. Do you know what that was?
Syphilis and gonorrhea?
It didn't work for gonorrhea. Yeah, it worked okay for chlamydia. All right. So my thought on this is caution. We really don't have a position statement on its use. With this concern about growing resistance to Neisseria gonorrhea, I think this can become a problem. It's been used in skin management for quite some time, but who knows if you roll it out for this, if we're going to be able to get this done and know if it's safe and effective. So I say not ready for prime time. Here are the learning points for the case. Thank you so much for your time and the work that you do. So if you have any additional questions that are unanswered, please feel free to fill out the evaluations. You can enter them there. We're happy to provide any additional information. The slides should